Picture an elementary school classroom. A young student is shifting constantly in their chair, repeatedly interrupting the teacher and blurting out answers before the question is even finished. At the extreme end of this behavioral profile, you might see a child who physically cannot wait their turn, pacing or running around the room as if driven by a motor. In a typical well-resourced district, these specific, highly visible actions trigger a standard administrative response. The teacher initiates a referral for a medical evaluation. But when Black and Latino students in Georgia exhibit these exact same classroom behaviors, the administrative response splinters in a different direction. Instead of receiving a medical referral, these students are routinely handed office discipline referrals, detention slips, and out-of-school suspensions. This divergence represents the center of the pediatric ADHD equity gap, a system where identical neurodevelopmental symptoms result in medical care for one demographic and punishment for others. Teachers and school administrators are almost always the first adults to interpret a child's actions during the day. When those evaluators lack specific cultural context, they frequently misinterpret underlying neurological traits as willful, defiant behavior problems. For the mislabeled student, the fallout is immediate. They lose academic momentum while sitting in the principal's office, and their self-confidence erodes under the label of being a bad kid. Treating a biological condition as a behavioral failure effectively locks marginalized students out of the evidence-based care they need to succeed. To understand what these students are missing, we have to look at ADHD combined type as a strict neurobiological condition rather than a failure of discipline. This Venn diagram maps out the clinical criteria. Diagnosis requires severe symptoms in two overlapping categories: inattention and hyperactivity or impulsivity. Per the DSM-5, these must appear before a child's 12th birthday, occur in multiple environments, like home and school, and cause clinical impairment. When schools ignore these strict clinical criteria in favor of punitive discipline, they are actively penalizing a student for their own biology. The established medical standard for managing this biology is known as multimodal treatment. This begins with non-medical behavioral therapy, which involves training parents in behavior management and helping the student develop practical organizational skills. Next, it requires specific classroom accommodations, like assigning preferential seating, allowing frequent movement breaks, and breaking down complex task instructions into smaller steps. The final tiers involve dedicated executive function coaching, and when prescribed by a licensed clinician, the use of stimulant or non-stimulant medications. Access to every layer of this treatment matrix depends on a culturally competent evaluation. Evaluators face a complex task. They must accurately distinguish between behaviors shaped by a student's linguistic and environmental background and behaviors driven purely by their neurobiology. Without accounting for cultural context during that initial evaluation, the entire evidence-based treatment matrix remains out of reach for students of color. We can clearly see the devastating macro-level impact of this failure playing out across Georgia school systems. This bar chart tracks marginalized student populations in the state, revealing a persistent inverse relationship: low rates of ADHD diagnoses paired with disproportionately high rates of school suspension. These systemic gaps permanently derail academic trajectories, costing students their future potential and their classroom time. Punishing a neurobiological condition fails to fix the underlying cognitive challenge and serves to deeply alienate the student from the education system. Changing this trajectory requires moving the intervention point, bringing culturally competent care directly into the school building where the behaviors first present. This is the structure behind MentalSpace School. The model equips K-12 schools with dedicated, culturally diverse clinical teams that are accessible via same-day teletherapy. These teams deploy a comprehensive range of services, handling everything from initial ADHD evaluations and family counseling to immediate crisis intervention and suicide prevention. This financial graphic shows how the access barrier is removed. Medicaid covers the services with $0 out of pocket, alongside broad in-network coverage for private plans like Blue Cross Blue Shield, Cigna, Aetna, Humana, Peach State, CareSource, and Amory Group. The platform also eliminates administrative hurdles by maintaining strict compliance with HIPAA and FERPA, while actively supporting schools ahead of the upcoming July 2026 HB 268 compliance deadline. This countergraphic displays the real-world outcomes of the MentalSpace model an 89% improvement in student attendance, a 92% reduction in clinical anxiety, and an 85% satisfaction rate among participating families. Replacing punitive discipline with evidence-based mental health support treats the neurobiology of ADHD and narrows the state's long-standing equity gap.